So today we'll be talking about fidelity and adaptation. This is our seventh educational series. And myself, I'm Santana, and May will be presenting for you. So we are part of the Evans Center for Implementation and Improvement Sciences. We're a methodological hub for implementation science, specifically in safety net settings. And we provide guidance, support, and innovation in research design, as well as educate the BU and BMC communities on implementation and improvement sciences. So this eight-part series is part of our educational initiatives, and we hope to continue these next year as well. So how to engage with CIIS? You're here, you can attend our monthly educational seminars, as well as participate in research consultations with us. You can learn more at our website or get on our listserv by emailing ciisinfo@bu.edu. So this is our team. Mary Lynn is our director, and then Kirsten and Nick are co-associate directors. I'm the assistant director. Kayla here is our research specialist, and then we have a robust team of fellows, including Gabby, Catherine, Shayna, May, Katie, Rebecca, and Emily. So this is the schedule of the previous seminars we have done. We started in September of 2023. This is our seventh, and our last one will be on April 11th, and that will be on qualitative and mixed methods. We also have a YouTube channel with all of our previous seminars recorded. So if you missed them, you can check them out. You can just Google CIIS YouTube, or here's a QR code that'll take you right there. Today, we will be discussing fidelity and adaptation. So our learning objectives for you all are to define the concepts of fidelity and adaptation and really consider the ways in which they interact. Also to understand the benefits and challenges of program adaptation and describe methods to adapt an evidence-based intervention for new settings and populations, including using frameworks and structured processes to do so. So we'll start off by discussing the concept of implementation fidelity. And this here is a conceptual framework that outlines various elements of fidelity. So one way to conceptualize fidelity is adherence to the evidence-based or informed intervention. So generally, was the overall intervention delivered as intended based on the evidence? Second, exposure or dose. So did participants get the exposure that was intended with the appropriate dose and duration of the intervention? And was it delivered with high quality? Sometimes implementers, go through the motions of these efforts, but are we really getting the high quality of delivery? And then participant responsiveness. So did the participants respond and engage adequately? Was there impact? And then this idea of program differentiation. It's often referred to as the core components of programs. So we're the fundamental elements that make the evidence-based intervention function adequately delivered as they were intended to be. So program differentiation is a really crucial aspect to fidelity in order to identify both unique features of the program components and then which of these elements are considered essential. And by essential, we mean that these are really the active ingredients of an intervention that are responsible for achieving the intended outcomes. The CDC National Center for Injury Prevention and Control provides a really helpful framework for understanding these essential elements, including what the program contents and standards should be delivered, how they should be delivered, and then the characteristics of who should ideally deliver or lead an approach. So this figure shows these essential elements, the what, how, and who of programs at both the individual and interpersonal levels, as well as community and societal level approaches. And these examples are in the context of violence prevention, but can be applied to other types of programs as well. So the what encompasses the actual program content, including, the messages delivered to recipients through the intervention. The how and the who encompass the actual delivery, including effective implementation strategies and stakeholders for delivering the intervention. And estimating these essential elements can help implementers select strategies and guide decisions about program delivery and adaptations that help maintain that fidelity and achieve outcomes in a variety of unique local contexts. In some cases, the essential elements of an approach have already been identified by the intervention's developer. But if they're not already identified, or if they seem unclear to the practitioner or the implementers can use both formal and informal core component analysis to identify the active ingredients of the program. And the purpose of estimating these essential elements is to understand how the evidence-based intervention is intended to work and the potential consequences of making changes, modifications that may affect the what, how, and who of what really makes the evidence-based intervention produce those intended outcomes. So intervention component analysis, or ICA, is a formal and rigorous yet relatively streamlined approach to identify key components of an intervention and how they contribute to its effectiveness in real-world settings. We won't go too much into detail about ICA, but generally it involves dissecting the intervention into its constituent parts and then examining their roles in achieving the desired outcomes. So by systematically evaluating each component's impact on implementation success, researchers can identify which elements are essential for effective implementation. And this really helps in optimizing interventions for broader adoption and scalability by pinpointing the most critical components and potentially streamlining implementation processes. Implementers can also use less formal and systematic approaches, including considering common essential elements of similar programs, referring to the approach's logic model that identifies stated outcomes and how actions lead to outcomes. And if no logic model is included, the process of actually building a logic model for an intervention may also help identify those essential elements. And implementers can also seek input from others who have had experience with the intervention, including previous program participants, practitioners, and even funders. So there are a variety of ways to identify core components, but even as a team, we've discussed how difficult it is to actually identify which of those various program components are considered essential during this adaptation process. So now moving on to the concept of adaptation. Program adaptation is often necessary because despite the evidence obtained through developing and testing evidence-based interventions, many interventions fail to meet the intended outcomes once they're delivered in real-world settings due to contextual factors. So in order to address this problem, program adaptations include planned changes to increase the impact and relevance of an evidence-based intervention. In other words, they're modifications to an evidence-based intervention, or EBI, to facilitate its feasible, practical, and acceptable implementation in new contexts. So in an ideal world, adaptations to an evidence-based intervention shouldn't be necessary. And this is because, as we've discussed in previous seminars, to be considered evidence-based, an intervention must go through rigorous evaluations to prove that it's effective, often in a series of trials in both controlled, so efficacy trials, and real settings, effectiveness trials. And the idea behind this process is that if an intervention can show positive effects, even in an effectiveness trial, so real settings, then it's ready to be disseminated and implemented across settings without major adaptations. But contrary to these expectations, adaptations to evidence-based interventions are common. And the literature suggests that up to 85% of evidence-based intervention users have reported modifying some part of the original intervention, such as the procedure, dose, content, format, or the target group. And these adaptations are often motivated by differences between the context for which the EBI were designed and then evaluated, and the context in which they're being used and implemented, leading to really a misfit between the evidence-based intervention and then the context of its application. And so this gap must be addressed. And although studies show that high fidelity is associated with better outcomes than low fidelity, other studies have suggested that adapted evidence-based interventions may be more effective than non-adapted evidence-based interventions. So this tension has been referred to as the fidelity adaptation dilemma. And this kind of implies that there's a matter of either or fidelity or adaptation. So to reconcile this dilemma, we then ask, can fidelity and adaptation coexist? And the short answer to that is that contemporary conceptualizations tend to suggest that fidelity and adaptations can be balanced. So the relationship is both, not really either or. But reconciling the paradox between fidelity and adaptation requires considering how fidelity and adaptation should be managed so that the intervention can fit a specific context while also retaining its core components. This ensures that the adapted intervention is at least non-inferior to and possibly better than the original version. And this can be achieved through either adapting the context by removing obstacles to high fidelity, or by adapting the intervention to fit the context. For example, by modifying components that aren't really applicable or feasible in a specific context. And then in order to ensure thoughtful decisions that promote the fit without threatening the integrity of the intervention, adaptation decisions should be made using a really structured process involving multiple stakeholders and experts on the intervention, implementation, as well as the local context. So stakeholders should convene to make these decisions proactively and with careful consideration of how they might affect the intervention's core components and effectiveness. So this is an example of a relatively simple and practical process to make and track adaptation decisions. Using this form, implementers describe the adaptation being implemented or made, the population that adaptation will be applied to, the reasons that influenced the decision to adapt the program in the first place, and then the decision-making process for creating the adaptation and what is involved in the actual implementation of the adaptation. Marilyn, this form comes from you. I don't know if you have anything to add about it or discuss your experiences using this form with adaptation decision-making process?
Man, sorry, I was trying to mute. Still not very good at this. No, I found like it's just helpful to have any kind of a tracking because you lose track. And, sort of writing it in either there's like a process called frame or others, but we kind of use that process so we can really talk through the adaptations. Nothing important except that I think it's really important.
Great, thank you. And
Yeah.
yeah, we'll next be going into some formal frameworks that can kind of augment and help formally and systematically tracking this decision-making process. But as Marilyn noted, it's extremely important, whatever way that you choose to do it, to systematically document the adaptations, and I'll explain why in a little bit. So there are also these several models and frameworks that have been developed to structure and support the process of making decisions regarding adaptations. And again, the purpose is often to enable the adoption of the intervention by facilitating the dissemination of evidence-based interventions in settings that may differ from the EBI's original developmental context. And these models consist of very elaborate, yes, Marilyn? You're muted here.
I know. I think that one of the things is that we developed that simple form because frame is so complex that it's probably really important, but it sometimes all this documentation can get in the way of the doing. So I guess, trying to balance what I always think of an implementation in science is trying to balance rigor and relevance. This is, I think, a great example of where frame is really useful, but it's quite detailed. Although you could make it a checkbox and maybe it would be easy. But I found the other structure more useful for me in my work, just personally. Now I'll shut up.
Yeah, I think that's a great point and something that we raise. And yeah, even just looking at this is quite overwhelming. So using it as a framework, but then creating more practical checklists, worksheet, whatever you want to do is more practical in your own work. I think that is a great idea.
Can I ask a quick question? Do you use this framework like where in the process do you use it, when you're deciding that you need to adapt, or after you adapt, or as you are adapting, or is it used all three?
Marilyn, did you have a response?
I usually use it I think you could use it free too if you're thinking about what did we do to plan this, but definitely as, because sometimes, in this work, it's not linear, right? And you might make a tweak to who engages in this, or, or maybe you don't have control over it. Maybe you're working with an organization, right? And they decide that we're going to let this new team do this. So, just noting it and like dating it and just noting it. So I think that all the way through for me, at least.
And I think that this framework supports that idea as well, as you're using it all the way through the process, because this model really consists of processes involving multiple steps. So the identification of the mismatches that require adaptations in the first place, but then there's also components on pilot testing and evaluating the adapted version. So that spans across all implementation stages, from pre-implementation, as you're discussing what needs to be adapted and why, but then also tracking and evaluating the implementation and sustainment of those adaptations and how they affect implementation outcomes. Okay. So this framework really highlights the wide variety of adaptations that can be made to a given intervention. And as we think about building an evidence base and allowing others to benefit from it, it's really important to systematically document all the modifications that we make when implementing the intervention, in addition to the rationale and justification for making those changes. because then our evaluations become much more useful to the broader field and community. Because if you say that this is my modified version and it worked in this type of community, then someone else can apply those same or different modifications in a similar or different context. If you just say, you know, we made these cultural and contextual adaptations without really specifying the modifications and why, then you won't really know what the effectiveness data relate to. So the greater detail into what adaptations were made, including the rationale, others can really benefit from that decision-making process and customize the intervention to meet the needs of their study population better. So now I'll hand it over to May. She'll continue to provide some more examples of adaptation frameworks and case study.
Great, thank you, Santana. So following on what we were just discussing, another kind of model for thinking about sources or different ways in which you might adapt an intervention is the adaptome. And I think it provides a nice visual for thinking about what aspects of an intervention might be adapted. So the adaptome breaks it down into service setting adaptations. So are you changing who's delivering the intervention? Are you evaluating how it fits with other interventions in your setting? Another source of adaptation might be adaptation specific for your target audience. So are you adapting your intervention to make it more age appropriate, to meet the health literacy level of your population, or to respond to maybe comorbid conditions for the audience that you're targeting? We can also think about mode of delivery adaptations, and these might be things like changes in the number of sessions, or maybe the technological format. Maybe you're going from an in-person intervention, you're wanting to change it to a video-based or remote intervention. We also think about cultural adaptations in terms of maximizing fit for the community that you're working with in terms of the imagery that's used or consistency with belief systems or language. And then finally, although we don't advise against changing core components, making sure that the core components of the intervention are really well identified, as Santana explained, through rigorous methods, and then being clear if you are going to adapt a core component, being very clear about that. So adapted is a systematic adaptation process that was developed by Wingood and colleagues. And this came out of the HIV literature, but has now been used in a kind of a wide range of different health topics. And it's basically a staged approach for systematically adapting an evidence-based intervention. So first you would use the literature to kind of determine whether you're going to adopt or adapt an intervention. And then if you're going to choose to adapt the intervention for your setting or your population, you would start to produce an adaptation plan and convene topical experts who provide substantive content and technical assistance to help you decide what kind of adaptations are necessary. Then in the integration step, you would integrate all of those forms of information and then train your relevant personnel in your setting on the adaptations. And then the testing phase is really pilot testing the intervention, ideally with iterative feedback for improvements to be made before you then officially roll out the adapted program. So I'm really happy to present a case study from CIIS. This is Gabby Ramos's CIIS project. And so she adapted a social determinants of health screening and referral intervention to the NICU setting here at BMC. So the evidence, and I'll let Gabby, who's on, chime in as needed, or as she wants to. So the EBI was a social needs screening and referral to resources. And Gabby and her team identified the core, through the literature, it was identified the core elements of the EBI, which was a standardized social needs screening using a tool, and then subsequently referral to resources in the community. And the rationale for adapting rather than adopting the Thrive as it was initially developed was that the EBI was developed for outpatient settings during well-child visits, and acknowledging that the NICU setting is fundamentally different from the outpatient pediatric setting with respect to clinical acuity of the patient's workflow, family provider interactions, and the duration of clinical care. Following the adaptive framework, this is kind of how Gabby and her team went through their project. So first with the assessment, which is, identifying who is a new target population and why is this intervention important for them. And so their methodology was looking at their own previous research and doing a scoping and literature review, and also conducting a needs assessment with NICU staff and families. And they found that there was a high burden of unmet basic needs among low-income families of preterm infants, and that unmet needs were associated with worse child outcomes. So then in the decision phase of kind of what EBI and should it be adopted or adapted, as we previewed, they decided to adapt the Thrive intervention to the NICU context. And then in terms of administration or deciding what in the original EBI needs to be adapted and how should it be adapted, they conducted interviews with stakeholders and focus groups with NICU families. And this resulted in changes to how the screening was asked, what was asked, and how positive screens would be responded to. And then production, which is how do you produce a draft of your adaptations and document it. Gabby and her team developed NICU Thrive based on the feedback from interviews and focus groups, and then developed the adapted tool and established procedures for integrating NICU Thrive into the workflow. Any comments on this, Gabby, before we move to the next slide?
No, you covered it all.
So the next phase in the adapted is topical experts, so who can help. So Gabby's team reviewed NICU Thrive with the original tool developers, the VP of Mission, and also health equity researchers to gain their input, and met with partners from community-based organizations. And as a result of this phase of adapted, they added questions on managing money. They revised the format of resource guides, and the adaptations were then presented back to family partners. In the integration phase, which is what is going to be included in the adapted EBI that's going to be piloted, they kind of developed the NICU Thrive 2.0, conducted readability testing, and then translated the tool into 4 languages. So the outcomes of that phase were the NICU Thrive 2.0 tool and resource guides, which were improved for the setting. And they developed scripted messages to help normalize the screening process. The next phase was the training phase. So they trained screeners, which for the NICU context were the bedside nurses, and trained local champions. And so they developed video trainings depicting various scenarios and a manual for documentation in the EHR. And then the next phase is testing. So kind of evaluating, was the adaptation successful and did it enhance short-term outcomes? So in this phase, they pilot tested the tool with NICU families, and conducted interviews with families after discharge and measured the acceptability and feasibility from the staff perspective. So these implementation outcomes were acceptability, feasibility, penetration, equity, and patient-centeredness. And they also looked at effectiveness outcomes. So enrollment in new hospital or community services, resources. Anything to add, Gabby, before we move on?
Yeah, no, only that the adaptation process kind of took for us about 6 months. So kind of like planning ahead, but like it also helped us, the tool, like the actual evidence-based intervention was being adapted, like the procedures to put it in place were also adapted. And so just kind of like think for teams to think ahead of how long it will take you, but like also to make the most out of that time, because it does delay kind of like when you start doing things.
Thank you. Yeah, I think that's really helpful to build, to have a timeline in mind. All right. So we walk through the adaptive process, and with Gabby's example, I think another kind of helpful framework for thinking about adaptations is this traffic light framework, which was developed by the CDC. It may be particularly useful for practitioners in community settings that provides a lot of kind of, I'd say, practical guidance on adaptations. And so they So in this framework, green light adaptations are a change that doesn't alter or diminish core components. Yellow light adaptations are more complex changes that one would approach with caution and recognize that they may require expert assistance to avoid compromising fidelity. And then there are red light adaptations, which might be like reducing or eliminating activities, and that might substantially compromise those core or essential elements of a program, and that those types of adaptations should be avoided. So here are some kind of examples of green light adaptations, or what we consider kind of safe adaptations. They might be things like kind of how you package your intervention, so updating statistics that are relevant for your target population, customizing scenarios, changing word choices or language, replacing images or cultural references, or using different outreach methods. The CDC considers yellow light adaptations as the kind of the more intrinsic characteristics of the intervention. These might be things like changing session number, length, or order, adding additional activities, lowering participant engagement, eliminating key messages or skills, or removing topics or sections, or using untrained staff or volunteers, or limiting the number of staff that are involved. So some of these changes might, be specific to a low resource organization or a low resource context, where you might have to make some of these adaptations to make the intervention work with lower resources, but the advice is kind of proceed with caution. And then the red light adaptations might, consist of those adaptations that would delete core components or whole sections of the program, that would significantly change the program timeline or dosage, maybe changing the entire health topic or behavior. So for example, if you're working on a different health topic that there's not an evidence-based intervention for, you might need to model or adapt another intervention for that. Or kind of changing the underlying theory or model of change. And then I see a comment from Mary Lynn, so it might be good to talk about it now. Oh yeah, in terms of the yellow light, yeah, so Mary Lynn is saying that sometimes changing the session number or lowering participant engagement could be thought of more as a red light adaptation. It was presented as a yellow light adaptation, so I think that that's right. I think if it's a substantive change to the dosage for participants, then I think it would be right to consider it more of a red light adaptation. So I think that's kind of a more nuanced point.
Yeah, I don't know how to draw the line, right? If it were me,
Yeah,
yeah, if somebody, how do you draw that line? I think that's always the question of what's a core. I
yeah,
just wonder what
absolutely.
people think. Because to me, that's changing dose, isn't it? Or I don't know what it means by changing participant engagement exactly.
Marilyn, is this similar to like when we kind of eliminated the 28-day oral lead-in, and we decided that, oh, we can skip this, and now because people didn't like doing it, and then just go straight to the injection? Is that like
Except that was
similar?
a drug, right? And that was
Yeah.
yeah. But I mean, in some ways, right? Like if you're saying like, oh, this is like, maybe I'm thinking about some of the work that May does where people have a bunch of sessions. And what if you said, well, they only really need to do 3 sessions instead of 5 sessions? Is that more red? I don't know the answer. I mean, I think this is where we struggle. These other things are really clear to me. I think, but dose is set, I don't know. I mean, I don't think we know the answer.
Yeah, I think dose is really hard, and I think
Dose is really hard.
and I think you might think about the so my research is around parent-child interventions, or PCIT, which is typically an 18 to 22 session intervention, so might be really impractical for some families. So there's a lot of adaptations that have been tested that reduce the dosage, but I think to maybe 6 sessions, for example. But then you also want to think about if it's a child who has a lot of clinically significant problems, maybe that adaptation isn't appropriate for that family. So also then choosing who's gonna, maybe potentially also thinking about your target audience for the adapted intervention. And are there some participants who require a full length or the original intervention versus an adapted shorter intervention as well? I think thinking really closely about your target audience too.
I don't know the answer. That's something that comes to my mind a lot when I think about adaptation. And I think it's a challenge.
This is a nice visual from the CDC thinking about violence prevention approaches, using that what, how, and who that Santana presented earlier. So I think this kind of illustrates some of the nuances about like, if is it green or is it yellow, or if it's red. Here they just present green and red. So for example, the session should increase in understanding that violence is a serious problem. And so the adaptation example here is the implementer changes a brief lecture about violence into a group conversation. And so this adaptation might be a green light adaptation if the key messages and activities about violence are delivered and then the discussion is well managed. But that actually might be a red light adaptation if in the group discussion format, participants are talking over one another or key messages and activities are contradicted. And another example is like how the session is delivered. So if the original program, the sessions are delivered for 60 minutes, and then the adaptation is to extend the length of the session to 90 minutes to help develop a rapport with participants. It might be a green light if participants are engaged in the activities and they have increased comfort with the implementer. But it could also be a red light if you lose the participants, they express disinterest or discomfort with the length of the session. And there's also the who. So, the core component or essential element is that the practitioner delivering the intervention should be at ease discussing the content and facilitating the discussion. And the adaptation might be having a different level of provider or a substitute delivering the session. And then thinking, this could be a green light if the person delivering the substitute understands and buys into the key messages and delivers them in an engaging manner. But it could be red light if the substitute practitioner doesn't believe the key messages or reads the curriculum verbatim. So I think these examples just help to illustrate Mary Lynn's point about sometimes it might not be clear at the outset if it's a green light or a red light intervention or how different adaptations may play out in practice. So to be thoughtful and mindful of that. So in terms of recommendations to advance fidelity research and practice would be to, first, as we talked about, to examine elements of and barriers of evidence-based interventions carefully. And when you are going to adapt an intervention, to make sure that you're monitoring fidelity and also documenting the adaptation process. And then we have a couple of, we welcome some questions before we get to our summary slide, but these are from the audience, but we also had some discussion questions that came up for us as a group as we were thinking about adaptation and fidelity. So I'll we'll leave these questions up here, but also really welcome questions from the group.
I'm curious about what people think about something we talk about a lot as a group is, what is this line? How do you know when you're done? One of the things in a lot of my work that I've been doing is a lot of co-design work with people who speak different languages and, most likely are from different cultures as well. And if we co-design materials in 5 languages, 6 languages, and we've gotten participant buy-in, then in the next 6 languages, is it sufficient to just have them translated and have them looked at by native speakers to make sure the words are used the same way, and maybe 2 or 3 native speakers for each one, versus, because I feel like you'll never finish and will sort of be in danger of sort of letting the research drive everything instead of letting, moving evidence into practice. So I guess I'm curious, that's always something that I struggle a lot with, is where either, I guess it's partly bullet 1 and partly bullet 4. Like, how do you know when enough is enough? I'm curious about what people think.
I guess along those lines, it kind of also includes bullet one, yeah, like I guess it's kind of also if you determine if, so for example, we're talking about making changes based on language, for example, but even if people speak the same language, adaptations might not work across two English-speaking groups, for example. You know what I mean? And we discussed today, like if you have an English-speaking person from the Caribbean and an English-speaking person from Europe, even though the intervention is in English, it still might not work in those two groups. So I guess it's also talking about language adaptations and, as bullet one says, like cultural and contextual adaptations as well. Yeah,
Yeah.
no, it's a good question. I have no idea exactly where you would draw the line.
Yeah. Yeah, I'm wondering, Gabby, if you might comment about your NICU work and how you do that line. And then, yes, we should love to hear from Karina as well.
Yeah, I actually didn't think of translation alone as an adaptation. We did learn from our qualitative work with families that, for example, Hispanic families had a different view about disclosing and requesting social services just from like a cultural background, like the differences in their cultural background. But the way we tried to adapt this intervention to the NICU is so that it would be sensitive to various cultures, to a more general population. So when we translated, like that was just like one more step. Like we didn't really get a sample of like all the different languages and like tested it. Like I don't know if we should have, but I didn't think of just translation as a major adaptation.
No, I agree, Gabby. It's not the translation, not the adaptation at all. But the point is, like, when do you stop, right? Because if not, you'll just, I mean, there's how many languages are there? How many cultural groups are there? So where do you, how do you sort that out? How many countries are there where people can come from? I don't know the answer, but it's one I struggle a lot with. Because wanting to do the right thing.
Yeah, I think Gabby's example is nice in terms of like pragmatically kind of being attuned, using the qualitative research to kind of guide what might be some of the cultural contextual factors for families. And then you probably had a timeline and then wanted to translate and then pilot test it. But I think the pilot testing part is really important too, because I would imagine that if things came up in pilot testing, you might extend the pilot testing phase for iterative adaptation. So I think a lot of the adaptation process involves iterative cycles of adaptations, which I think, is you still would have to decide when to draw the line, but at least it would be guided by the results that you're getting from as you're piloting it. And then Karina, if you want to unmute and talk to us a little bit about your example in the chat, that would be great.
Well, are you guys listening to me? My English is not so good, so I always try to participate by the chat. My point of view that I bring for you guys, it's about the team that is in fact involved in the operational lines. I brought this example. We received a huge protocol to apply in our institution. It was about maternity, morbidity, and mortality from our government. And it was really, really hard because people that were acting in the front of the emergency room, they were not listened and not involved in the beginning. So it was hard for them to receive something, ready. It's about this point that I brought for you to think about.
I think that's a great point and goes back to my discussion of the importance of involving multiple stakeholders through the decision-making process about how to adapt a program, and to really listen to and incorporate the voices of not only the implementers, but also people that really know the local context to decide which adaptations need to be made and how to implement those changes.
This is really, really great discussion that we're having. And so I'll present a summary slide, and then we might still have a few more minutes for questions or more discussion. But, I think in summary, we'd want to think about balancing fidelity with strategic adaptation. Frameworks can provide adaptation guidance, and well-established programs include, the core components, adaptable elements, implementation guides, and monitoring and evaluation. And that established processes such as Adaptit can provide structure for practice-based adaptations. So with that, we want to put in a plug for our next session, which will be qualitative and mixed methods on April 11th from 1 to 2 p.m. And we would love to gain your feedback about today's session. So please use that QR code to fill out a brief survey and help us continue to improve these sessions. We also wanted to make an announcement that an implementation science faculty position is now open. So the BU Department of Medicine is recruiting a senior or a full or associate professor level investigator to join our faculty and co-direct our Evans Center for Implementation Improvement Sciences. So we're looking for candidates who have expertise in implementation science research methods. And if you're interested in more information, please contact Santiana at her email address.
And I'll just go back to this QR code for completing the evaluation survey. And if anyone has any more questions, insight, we are here for a few more minutes.
And I think adaptation does make my head spin too, Emily.
Mm.
Not my thing for that reason. It's too hard.
It's like you're saying, it does seem like it feels like you could adapt for more specific situations forever. And like we're talking about sort of that line between, when do you need to do it? What's sort of good enough? When is, I don't know. Anyway, this was really helpful. Enjoyed listening to the presentation.
It's so interesting. In almost every review about using implementation science to advance equity, they highlight the need for adaptation. But I wonder, like, exactly what you're talking about. Like, when does the line end? Like, if this works for like a marginalized population, like, then how much adaptation does it need to be applied to a different context serving another marginalized population? But like, I guess hybrid designs are kind of like the way to go. If you are going through the process of adaptation for whatever reason, especially if it's for like a slightly different population, like particularly if you're doing some adaptations that are removing sessions or like changing dose of something, then testing for effectiveness will be particularly important.
That's an interesting term, modulation.
Yeah, and I've also wondered too, like, do you have to see a program kind of, sometimes I think reviewers will ask for evidence that you need to adapt the program. So thinking about like, sometimes an adaptation might conceptually make sense, but other times folks might ask you for evidence that it needs to be adapted. So thinking about, do you need to deploy the EBI first with a population and see if it works? Or can you rely on other literature to kind of guide if an adaptation is required to the EBI prior to implementing in your context or setting?
That makes sense to me. I'm not sure there's a perfect answer here.
Well, thank you for this wonderful discussion as always. And we hope to see you all on April 11th.
Thanks, everybody.